Hirsutism is the growth of excess terminal hair in androgen-dependent areas in women. For example, face, chest, abdomen, lower back, upper arms, and thighs. Hirsutism occurs because of the effect of increased androgens on the pilosebaceous unit, from which the hair shaft appears, increased pilosebaceous unit sensitivity to androgens, or the peripheral metabolism of androgens. Hirsutism is different to hypertrichosis, which is increased hair growth in a generalized non-sexual distribution and is unrelated to androgens. When hirsutism in women is accompanied by other signs of virilism, it may be a manifestation of a more serious underlying disorder causing hyperandrogenism, such as an ovarian tumor or adrenal neoplasm. Polycystic ovary syndrome is the most common cause of hirsutism, more than 70% of cases. Idiopathic hirsutism, a diagnosis of exclusion where there is no apparent underlying cause, normal serum androgen concentrations, normal ovulatory and menstrual cycles, and normal ovarian morphology, is also common, accounting for around half of women with mild hirsutism. Idiopathic hirsutism may be a result of increased sensitivity to androgens in the pilosebaceous unit, enhanced local conversion of testosterone to dihydrotestosterone by 5-alpha reductase, or altered function of androgen receptors. In menopausal women, reduction in estrogen and progesterone production can result in hair and skin disorders. The reduction in progesterone can increase the influence of androgens on the sebaceous glands and hair follicles. Less commonly, hirsutism may be caused by non-classical congenital adrenal hyperplasia, Cushing syndrome, acromegaly, hyperprolactinemia, thyroid disorders, drugs. For example, anabolic steroids, cyclosporin, danazol, phenytoin, sodium valproate, and tamoxifen. Tumors, androgen-secreting adrenal tumors, androgen-producing ovarian tumors, e.g. luteoma of pregnancy, arenoblastomas, Leydig cell tumors, Hiller cell tumors, thecal cell tumors. Other causes include severe insulin resistance, anorexia nervosa, prolactinoma, acromegaly, hypothyroidism, and porphyria. Complications of hirsutism. Hirsutism can have adverse effects on psychological well-being and quality of life, including low self-esteem, depression, and social difficulties. For diagnosis, look for excessive terminal hair in androgen-dependent areas, including the face, chest, abdomen, lower back, upper arms, and thighs. Terminal hairs can be clinically distinguished from vellus hairs, soft, short, lightly pigmented, because they are longer, stiff, and pigmented. The Farah-Mangawi scoring system is the gold standard for evaluating hirsutism and includes 9 androgen-sensitive body areas. Each area is scored from 0, no hair, to 4, extensive hair growth. A score of 8 or above is considered to define hirsutism in UK Black or white women of reproductive age. Normal scores are lower in some Asian and South American populations, and higher in some Mediterranean, Middle Eastern, or Hispanic populations. However, the Farah-Mangawi scoring system has limitations because it is subjective, does not include some androgen-sensitive areas, such as the sides of the face, can be affected by previous cosmetic treatments, and does not account for locally high scores. An individual score may not correlate with the level of distress excess hair causes the woman, and it has not been carefully validated in postmenopausal women. Lower Farah-Mangawi total scores than those defining hirsutism in women of reproductive age may also be clinically important, and treatment decisions also depend on the importance of the hirsutism to the patient. History and examination. The task is to establish whether the hirsutism is androgen-mediated, and if so, the cause of excess androgen. Further investigation is indicated if there are features of androgen excess, rapid progression, infertility, or menstrual irregularity. Signs of hyperandrogenism, acne, alopecia, temporal hair recession, male pattern, truncal obesity, clitoromegaly, deepening of voice, increased libido, increased muscle mass, primarily shoulder girdle, loss of breast tissue or normal female body contour, malodorous perspiration, infertility, menstrual dysfunction. In history, ask the patient, age of onset, rate of progression, menstrual history, age of menarche, medication, including over-the-counter preparations and anabolic steroids, family history of hirsutism, level of distress caused by hirsutism, associated symptoms e.g. acne, weight gain, androgenic alopecia, galactorrhea, visual disturbance, headache, deepened voice. Ask about and look for features of underlying conditions, such as polycystic ovary syndrome, PCOS, including oligomenorrhea or amenorrhea, infertility, acne, central obesity, and acanthosis nigricans, an androgen-secreting tumor, including sudden onset or rapid progression of hair growth progression despite treatment, signs of virilization, hair loss from the scalp, voice deepening, increased muscle bulk, clitoromegaly, and a pelvic or abdominal mass. Endocrine conditions uncommonly cause hirsutism, including Cushing's syndrome, facial W, weight gain, moon face, central obesity, fat deposition on the upper back and between the shoulders, stretch marks, easy bruising, and proximal muscle weakness. Non-classical congenital adrenal hyperplasia, family history of adrenal hyperplasia, menstrual dysfunction, infertility, thyroid dysfunction, abnormal thyroid function tests. Hypothyroidism or hyperthyroidism is uncommonly associated with isolated hirsutism. Hyperprolactinemia, galactorrhea, amenorrhea, infertility, infrequently presents with hirsutism. Acromegaly, increased size of hands or feet and mandible, frontal bossing, deepening of voice, rare cause of isolated hirsutism. Ask about current medications. Certain drugs, including danazol, sodium valproate, and anabolic steroids, can cause hirsutism. Ask about family history of hirsutism or hyperandrogenism. Pelvic mass, originating from an ovary on bimanual vaginal examination or adrenal tumor. All women with an abnormal hirsutism score or local sexual hair growth with clinical evidence of a hyperandrogenic endocrine disorder, suggested by sudden onset or rapidly progressing hirsutism, irregular menses, infertility, galactorrhea, features of hypothyroidism or Cushing's syndrome, acromegaly, central obesity, test for elevated androgen levels, serum total testosterone level. If serum total testosterone levels are normal and sexual hair growth is moderate, severe, or sexual hair growth is mild with clinical signs of a hyperandrogenic endocrine disorder, for example, menstrual disturbance, measure an early morning serum total and free testosterone. In women with local, isolated sexual hair growth, a normal hirsutism score, and no other signs of a hyperandrogenic endocrine disorder, investigations are not usually necessary unless hair growth progresses despite treatment. Consider screening for non-classical congenital adrenal hyperplasia in hyperandrogenemic women and hirsute women at high risk, even if serum total and free testosterone levels are normal. For example, those with a positive family history or from a high-risk ethnic group, such as Ashkenazi Jewish, Hispanic, and Eastern European people. Measurement of early morning 17-hydroxyprogesterone levels in the follicular phase is recommended. Check with the local laboratory for details on when and how this test should be performed. Testosterone. If the total testosterone is normal and the hirsutism mild and isolated, a trial of treatment can be considered. If the total testosterone is normal, but the hirsutism is moderate to severe, or there are other signs of hyperandrogenic endocrine disorder, for example, sudden onset or rapidly progressing hirsutism, irregular menstruation, infertility, galactorrhea, features of hypothyroidism or Cushing's syndrome, acromegaly, or central obesity, measure an early morning serum total and free testosterone. Free testosterone is more sensitive and may be raised in PCOS. If the free testosterone is normal, this suggests idiopathic hirsutism. If the total testosterone is raised, further investigations for androgen excess should be conducted. NICE recommends referring to endocrinology if testosterone levels are greater than 4 nanomol per L, and referring urgently if testosterone levels are greater than 6 to 7 nanomol per L. 17-hydroxyprogesterone. This is raised in non-classical Ka. It can be measured in women with hyperandrogenemia and should be considered in all women with hirsutism at high risk of non-classical Ka. Regardless of testosterone levels, high-risk features for Ka include those with a family history of the condition and women from certain high-risk ethnic groups, such as Ashkenazi Jewish, Hispanic, and Eastern European people. This test needs to be measured in the early morning, during the follicular phase. Further investigations for hyperandrogestonism will depend on the clinical picture. Follicle-stimulating hormone, FSH. Luteinizing hormone, LH. Women with PCOS may have an increased LH to FSH ratio. Greater than 2 is common. 24-hour urine cortisol to rule out Cushing's syndrome if suspected. Cushing's syndrome is a rare cause of hirsutism, and exclusion is not necessary unless the patient has Cushingoid features. Pregnancy should be ruled out in women with irregular or absent menstrual cycles. Prolactin. Prolactin affects the menstrual cycle, and hyperprolactinemia can be associated with hirsutism. If prolactin concentrations are more than 1.5 to 2 times the upper limit of normal, other causes of hyperprolactinemia should be considered. TFTs. Thyroid dysfunction can affect menstruation, and hypothyroidism is associated with changes in hair. Ultrasound. Patients with either menstrual disturbances or clinical or biochemical evidence of hyperandrogenism alone should have transvaginal ultrasound imaging of the ovaries. Further investigations is indicated. Glucose tolerance test with serial growth hormone measurements if acromegaly is suspected. Lipid profile. HbA1c. Ultrasound CT, MRI. If an adrenal or ovarian tumor is suspected, MRI brain scan. If a pituitary tumor is suspected, assess the severity of hirsutism. Assess the severity of hair growth and the impact on the woman's quality of life, as this may guide treatment. A subjective approach is generally appropriate in primary care, using the woman's own perception of her condition and the extent it impacts on her quality of life. Refer urgently within 2 weeks to endocrinology if there is a possibility of an underlying adrenal or ovarian neoplasm. Features of androgen-secreting tumors include sudden onset or rapid progression of hair growth, signs of virilization such as voice deepening, increased muscle bulk, a pelvic or abdominal mass. Consider referral to endocrinology if another underlying endocrine condition is suspected that requires secondary care diagnosis and/or management. Use clinical judgment regarding urgency. For women in whom further investigations were performed, refer to endocrinology as appropriate. This includes women with raised testosterone level above 4 nanomol per L. Urgent referral is required if there is a possibility of an underlying adrenal or ovarian neoplasm, or testosterone level is above 6 to 7 nanomol per L. Elevated 17-hydroxyprogesterone levels. Management of hirsutism in premenopausal women when referral is not indicated. Encourage weight loss in women who are overweight or obese. Discuss methods of hair reduction and removal, such as shaving and waxing, as these will remain an important part of management. If hirsutism is mild and does not significantly impact on the woman's quality of life, reassure and advise that no additional treatment is required. If additional treatment is required, for women with facial hirsutism, offer topical eflornithine, depending on local prescribing policies. Advise that noticeable results take 6 to 8 weeks. If no benefit is seen within 4 months of starting treatment, discontinue treatment and refer the woman to secondary care. If improvement is seen, continued treatment is necessary to maintain the benefits. Once the cream is discontinued, hair growth returns to pre-treatment levels within about 8 weeks. Do not prescribe topical eflornithine to pregnant or breastfeeding women or women younger than 19 years of age. For all other women with hirsutism, offer a combined oral contraceptive YCOCA containing ethinyl estradiol as initial treatment, provided there are no contraindications. If the woman is at higher risk of venous thromboembolism, for example over the age of 39 years, or obese, consider a COC with the lowest effective dose of ethinyl estradiol, usually 20 micrograms, and a low-risk progestogen. Discuss the risks associated with the use of the COC. The use of oral contraceptives for hirsutism is an off-label indication. Except for Dianet, cypertron acetate, and ethinyl estradiol, which is licensed for the treatment of moderate to severe hirsutism in women of reproductive age. Any woman with a history of meningioma should not take any cypertron-containing medications. If COCs are contraindicated or have not worked after treatment for 6 months or more, refer the woman to secondary care for consideration of a specialist treatment. Methods of hair removal. Treatments that can be done in a domestic setting and offer temporary hair removal include shaving, an easily available technique. However, it needs to be repeated frequently and leads to stubble. The blunt tip of shaved hair may give the illusion of thicker hair. Waxing and plucking. These are effective techniques, but they can be painful and may cause scarring, folliculitis, and hyperpigmentation. Chemical depilatory agents dissolve hair, but may be associated with irritant dermatitis and hyperpigmentation. Bleaching. This can mask the appearance of unwanted hair, especially on the face, but it may also lead to skin irritation and skin discoloration. Treatments carried out in specialist clinics may offer permanent hair reduction. They include electrolysis. This uses a small current of electricity to destroy the hair follicle. It is effective, but is time-consuming, can be painful, and is impractical for hair removal over large areas. Laser hair removal can be used over larger areas. It can be painful and time-consuming. It is most effective in women with lighter skin and darker hair. Management of hirsutism in postmenopausal women when referral is not indicated. Discuss methods of hair reduction and removal, such as shaving and waxing, as these will remain an important part of management. If hirsutism is mild and does not significantly impact on the woman's quality of life, reassure and advise that no additional treatment is required. Encourage weight loss in women who are overweight or obese. For women with facial hirsutism, offer topical eflornithine, depending on local prescribing policies. Advise that noticeable results take 6-8 weeks. If no benefit is seen within 4 months of starting treatment, discontinue treatment and refer the woman to secondary care. If improvement is seen, continued treatment is necessary to maintain the benefits. Once the cream is discontinued, hair growth returns to pre-treatment levels within about 8 weeks.